Thank you for tuning in to an Academy of International Mobile Healthcare Integration webinar. To ask questions, please use the double dialogue bubble button in Zoom please use the Q&A function in Zoom represented by the double dialogue bubble button. The chat function will be disabled for participants. This webinar is being recorded and will be available for on-demand playback on the AIMHI website tomorrow. The slide deck PDF was included in your reminder email and will be posted in the chat shortly. AIMHI Education Chair Zavadsky, would you please share some information about AIMHI?
Thank you, Amanda, and thanks everybody for joining. Amanda, I got to tell you, it still tickles me every time that you say double dialogue bubble button, and you said it twice, this time without a hitch. So congratulations to you. And again, thanks everybody for joining. Just a quick little background about the Academy for International Mobile Healthcare Integration. We are a group of high-performance, high-value EMS systems from across the US and Canada. You'll see some of the important parts of the EMS system delivery for those models here. You will typically see that these are public utility model systems that have been around for multiple decades. These systems do a great job with data, research, low cost, high reliability. And as we can go to the next slide, Amanda, we can actually show who some of those premier EMS systems are from across the country. We want to thank the members of AIMHI for sponsoring this webinar, which is a topic that is very difficult for many systems across the country. We occasionally see these in the EMS trade journals, some challenges with mental health transports. And I want to introduce Jonathan Washko, who is a member of AIMHI and was also a member of NEMSAC when they were addressing this on a national level. Jonathan, do you want to introduce this and then kick it off for us, John?
Thanks, Matt, and good afternoon to everyone. Or good morning, depending on where you're watching from. This is a topic that's near and dear to my heart. Matt and I had been kind of batting around the concept of behavioral health transport seminar for quite some time, and it really goes back to an incident that happened when I first came to New York. It's probably about 11 years ago now that our team will be speaking a little bit about, but it started to become a passion project of mine associated with really the elopement challenges that we see in the behavioral health transport aspects of what we do, and almost to a point that I think it's almost its own somewhat of a mini epidemic within EMS, because there is no way to actually track this nationally, like how many elopements occur within the industry, whether that's on the 911 side or the interfacility transfer side. But if you do a Google News search and you start to watch this, it's actually an extremely frequent occurrence. And quite honestly, from a patient and provider safety standpoint, it's probably up there, right behind the use of lights and sirens when it comes to injury, fatalities, those kinds of things. I would imagine. Again, that's just circumstantially driven. We have no data in the industry really to drive that. So definitely a passion project of mine. If you get a chance, the National EMS Advisory Council, who's the official council to FACPE under the Department of Transportation, put out, and I was involved with the committee that did this, put out a advisory on addressing patient elopement during EMS transport. And if you get a chance, go to ems.gov. You can actually download the advisory. There's 5 main recommendations that came out of it, dealing with actually creating a national database and a repository, helping EMS agencies to discover and understand the value of patient safety organizations, or PSO, and becoming part of a PSO and why that's so important. Talking about how we should create a brand new data element, or adding to an existing data element within Memphis about elopement as a disposition. They talk about convening an interdisciplinary team from many different stakeholders to come together and create kind of a white paper on the issue, best practices, and so on. And then finally, look to recommend amending the national EMS education standards in order to help providers as they're going through training, whether that be on the EMT side or the paramedic side, more about elopement, the signs of what to look for, how to protect yourself, how to protect your patients, and so on. So this webinar is really about focusing on the behavioral transport side of things, not so much the 911, but definitely, this problem exists on both sides. But at least in our world here in New York, have to be treated extremely differently, because in the pre-hospital setting on the 911 side, there's a whole set of rules and regulations that allow EMS providers to restrain. You have law enforcement with you. It's much more of a controllable situation, although not 100%, versus the behavioral health side, where, especially in New York, patients have a lot of rights. You can't just restrain someone. There's a lot of issues associated with it, and so Northwell's had to definitely come up with a whole new way of approaching these kinds of things. I've also had a chance to work a long time ago in Sunstar as a paramedic and as an administrator, and I know they've actually had an amazing program there for a long time, and I know Craig and his team will be talking about that program. So without further ado, I'm going to go ahead and introduce Craig Hare with Pinellas County, as well as Jasmine Solomon to kick us off on how Pinellas County manages behavioral health transport. Craig?
Craig, you might need to unmute.
Not sure, maybe we lost it. There we go.
We go. Oh, sorry, I hit the screen, maybe to unmute there. So thank you, Jonathan. I appreciate the chance to kind of talk a little bit about what we do in Pinellas County, and Jasmine will kind of walk us through a call. I'll give you kind of the background on our program. So mental health, just a thumbnail on the system. We're on the Gulf of Mexico in Tampa Bay, and our hearts really go out to everybody in Southwest Florida. South of us, we really dodged the bullet from Hurricane Ian. We are about 1 million population, 6 million tourists come and visit us, 24 cities, 18 fire departments, about 1,800 personnel, and we're a busy, metro system. So just give you a kind of thumbnail about what we're doing. So interesting background here. I'm a doctoral student now, so it's making me think about research and think about, are we bringing data and analysis to what we do? So a really good article that came out in 2020, a quick study that was done by this group here that and kind of things that we know intuitively. Hospital beds are decreasing, especially true for psychiatric beds. Emergency department visits are up, especially for mental health related. And then, also mental health related transfers are way up. So just kind of things that we know intuitively that we will, that we say, but a study to kind of support that. On the 911 side, we're a fairly traditional response, law enforcement first, fire EMS staging. Part of our protocol that we wrote in, because once in a while we had people, getting, concerned about leaving a patient. So retreating from a violent person is not patient abandonment. Our patient contact really focused our continuing medical education on verbal de-escalation, non-confrontational approaches. Making sure that we're not getting the tunnel vision of earlier responders. So when you think about law enforcement in a chase, or handling a patient and they go hands-on, us coming in and being calmer and more direct in our approach of what's the underlying cause, diabetic, hypoxia, all the things that we know, ETOH, head injury. Our physical restraint, we use both soft and hard restraints. Enough people, in order to make it safe. So because we're in a metro environment, very, high population density, we've got a lot of resources that are nearby. And so we put a lot of personnel when we've got hands-on with the patient. Chemical restraint, we are using Versed, IV or IM, and we can also give it intranasal. That can be repeated once in 3 to 5 minutes. That's really helped us kind of move away from just physically, fighting with people. And I think our law enforcement has really appreciated that approach. We do some direct training about positional asphyxia, and make that part of our continuing medical education. And that's really important to us when we, are interfacing with law enforcement, that, they maybe chase somebody down and cuff them, that we're immediately, putting them supine. We're kind of communicating the importance of airway when everybody's adrenaline is really hopped up, and then always, supine for transport. Specific training that we've done to back up law enforcement, help them de-escalate, and with professional manner of how we're interacting with law enforcement. So we really wanted to be humane, dignified, respectful, professional, even when the patient isn't, and kind of stepping back if any of our crew members are triggered into escalating behavior. We try to just tap them on the shoulder, pull them back, and just try to keep that calm and professional as much as we can. Something that we've reinforced to our folks here just recently is everything everywhere is on camera, and it doesn't always show the full context of what's going on, but we've had ring cameras and building and parking lot cameras. Of course, law enforcement now with dash and body cams. So very important to make sure that we're thinking about that. If law enforcement places them into custody, they must ride in with the patient during transport. That was something culturally that it took us a while to get there, but very important. And continued assessment if we've got restrained patients. So making sure that we're documenting that very strongly as we go through. And we looked at how the hospitals were documenting that, and we were a bit lacking, and that's something that we've really pushed on our documentation. We do try to get them to in Florida, a Baker Act receiving facility if they're stable, and then our involuntary transports are Baker Act, neglect or harm to self or others. That can be done by law enforcement, a physician, or a psychologist or your psychiatrist. Our Marchman Act in Florida is substance abuse or impairment, and that's law enforcement initiated. And we do have bane of our existence in Chapter 401 of Florida statute is involuntary transport if the patient doesn't have decisional capacity, and that can be EMS physician initiated. And we do that with an online consult to our on-duty doctor. We have our MHT, our mental health transport van service. We started that really probably 15, 18 years ago now. It's an unmarked passenger van for safe and dignified transport. We do that for medically cleared clients. It allowed us to reduce our costs to the hospital and increase our safety. We use a van with like sand barriers, outside locks, camera system, mobile and portable radio, BLS bag that's away from the patient compartment. Surprisingly on this, we use a single EMT mental health technician during the transport. The second provider is during pickup and drop off. So we took a while, but we got the training to our facilities that they have staff come outside with us when we're picking up and when we're dropping off. We also have a very strong, what we call a code H procedure. So anything comes up during transport, anything's not quite right, they either call in verbally on the radio, or they can hit a button on the radio to do a code H for help. And we're sending law enforcement, fire rescue, and ambulance and EMS supervisor emergency to assist. We can usually put somebody on scene, 4 minutes or so. And so that we felt in county was, a safe approach for us to make this a single mental health tech. When we've done that, we've had very few, knock on wood, elopements, and very few instances in which we've had somebody, swing or, get hurt or have to put hands on. Our specific criteria, which I think is really helpful for that, is we screen it twice, and Jasmine will walk us through a call, is we do it at the call tank, and we do it when they arrive to handle the transfer. So it has to be ambulatory, not exhibiting any current or recent violent behavior. So if they're tearing up the ER before we came, we're not going to put them to the van. Not high risk of elopement. We do a weapons check, and personal belongings are in a separate compartment from the client. Very important. I've seen that go sideways. So that was one of the things that we built into our processes. Physical restraint. only if safe to do so, calling for help, if they need it. In county only, that way we did a readily available backup to them. Out of the county, we're still going and it's either BLS or 911 or ALS. So if you look at our overall mental health transports, there's about 14,000 overdose, Baker Act, behavioral health, suicide attempt that we start out from the scene. About 50-50 are handled by EMS or are handled by law enforcement, the jail, school officials, hospital personnel. And so from there, about 62% are going to the hospital. About 8,700 cases there total to the hospital. EMS is taking about 6,900 of those. From there, we have a public health mental health receiving facility, and they do not have any medical clearance capability. So one of the things is we are taking about 25% of the patients that went in by law enforcement to the mental health receiving facility do have to be transferred to the hospital for medical clearance. And then we bring them back by van service. Also then hospitals residential treatment, we are doing about 80% of those are still EMS, ALS or BLS ambulance, and about 20% of those are mental health. So we do take a couple thousand patients by mental health transport van off the system. That's helped us a bit with a little crew fatigue of handling especially the very routine and very ordinary mental health transfers to take those off of the 911 crews. So that's helped us a bit. Since I've got the microphone, I'll talk about other things that we're doing that are mental health related. St. Pete Police is our largest city. They started a program for community assistance and life liaison, and we're taking a look at that. Instead of sending traditional law enforcement, fire, EMS response, they are sending community liaisons out that have mental health training and are able to really, reduce the response and have a good, approach to serving citizens with a less heavy response for alcoholism, substance abuse, opioid overdoses, that sort of thing. We have a number of things that are going on in the community with SAMHSA grants and our opioid overdose. We are consenting post-overdose patients so that we can refer them to a substance abuse treatment program. We're starting our Leave Behind Narcan program soon. Something interesting that we've done is we have a called a fusion group, where we've brought together EMS, fire, law enforcement, hospitals, forensics, medical examiner, public health, health and human services to really discuss emerging trends. So we started with spice and overdoses and the homeless, but any of the fentanyl analogs that have come up, this has really been great to pretty frequently share information and what law enforcement or what forensics is seeing out there, and making sure that then we're passing that back to the field. We do support our law enforcement training for Narcan, and we do a lot of data sharing with our public health and the countywide opioid task force. And then we are helping public health in our hospitals with medication assisted treatment, just supporting that. We really want to see that be widely adopted, community-wide. Also, it kind of brings out when you talk about mental health, wellness for our fire and EMS personnel. So we do have a standing committee that kind of deals with this. We put out Fire Strong as resource links for all of our personnel. We've adopted mental health first aid as our training, program and curriculum. That's based upon the Navy's stress continuum in 2007. We do a lot with peer training and peer network that we're using Redline Rescue as a backdrop for that. We do focus on safety stand down in June, but also May Mental Health Awareness Month. We're doing initial awareness training for all of our EMTs and paramedics when they come in. We're building in scenario-based for mental health first aid to our continuing medical education. So, hey, we handled this call, let's debrief it. Now, what would we do in terms of making sure that we're good? And then a gap for us is something that we want to start doing pre and post retirement or separation from service. We think that's an area where we really need to be, getting some good training as people are leaving the service. We do have pretty critical to us is a clinical psychologist with trauma certification and fire and EMS experience is embedded in our training, embedded in operations, and really has been, wonderful for us. We do have the Franciscan Center, which is Operation Restore. That partnership, they have a 4-day residential treatment retreat. And we treat it mostly as training. People self-identify, or we can ask them, if they want to go. But what they're doing that's proven to be very effective and hopefully something that you're seeing out there as well is the use of EMDR for treating post-traumatic stress. And then that's something that we really think has done wonders for us. Another soapbox of mine, since I've got the microphone, is non-fatal strangulation. So non-fatal strangulation in domestic violence is a very significant warning sign. A man that instinctively puts his hands around the neck is a potential killer. They're more likely to kill police officers, children, domestic partners. And very stark statistic is a woman who's suffered non-fatal strangulation, so being choked out during an episode of violence, is 750% more likely to be killed by that same partner with a gun. And then going for the throat in the moments of violence is a leading indicator of escalating violence. So that's something that we put out in our continuing education. The Strangulation Training Institute has a lot of really great information. We've partnered with our local, it's called CASA, maybe you have something similar that's for abuse victims and helping protect them. So we've partnered with them to make sure we're getting this information out and being an advocate for that. So next up, Jasmine will take it away and kind of bring us home on what we're doing in Pinellas County. Thank you.
Hello, my name is Jasmine Solomon. I'm the clinical director at Sunstar Paramedics, and I'm also an EMS instructor for Pinellas County. All right, so I just wanted to go over real quick what we do when we build a call for a mental health transport or when we have a scene response. So these calls come in on for interfacility transport on our non-emergency or interfacility lines, and the dispatcher follows normal dispatch procedures, and the call taker follows EMD and asks the normal questions: is the patient conscious and breathing? And then gets down to the reason for transport. And when the call taker finds that this is a Baker Act patient, there's 6 questions that they're asking to see if this qualifies as a mental health transport patient. So as Craig mentioned earlier, we ask, does the client need oxygen or any medical attention during transport? Is the client physically restrained or non-ambulatory? Does the client currently exhibit violent behavior, or are they likely to exhibit violent behavior during transport? Is the client high risk for elopement by statements made or behavior exhibited? And is the destination to which the client is being transported located outside of Pinellas County? If the answer to all of those questions are yes, the final question would be, is the client ambulatory, and can they safely get in and out of a mental health transport van without assistance? So once we get to that point, the decision is made. If all those answers are yes, and they can walk and get in and out of the van safely, they will go in our mental health transport van. This is staffed by 1 crew member, and this is a mental health transporter. This person has gone through 8 hours of training, not just by us. We actually work with the sheriff's office, and they spend at least 4 hours with an officer going through safety techniques and de-escalation techniques. So they would go in one of these vans pictured. Now, if one of those questions is a no, and the patient can't get in and out of the van, or they need any extra equipment or medical support, they would go in our BLS van, which is staffed by 2 crew members at minimum, and one of them will be an emergency medical technician. The other usually is also an EMT or emergency medical responder. So they will both have that training, and then the next level of medical training in our BLS van. So the other situation is if we have a patient that is recently sedated or restrained, or it sounds like they need a 3rd crew member, we'll put them in an ALS ambulance. They'll have at least 1 paramedic, usually a paramedic and EMT, and the 3rd crew member could be another paramedic or EMT or a student, but we'll have the manpower of 3 people. And this is for highly combative patients. Patients who are likely to have elopement or any other reason that we might find that they need that larger unit with that additional medical support. So our restrained patients would go in this unit. When we make scene responses, any scene responses would be transported by a BLS or an ALS unit. And all of our crews have been trained following our CME, and they've had extra training on how to safely de-escalate patients, and they have the tools that they need to ask for additional resources at any time. So basically making sure we're stringent with those 6 questions, make sure that our patients and our responders safely get to the most appropriate facility for their care. So let me know if you have any questions in the double bubble question box. And next up is going to be Jim Jackson from Northwestern Health.
Since you mind unmuting.
Jasmine, thank you very much. Appreciate it. Just give us a second here. Okay, good afternoon, everybody. Thanks for jumping on to attend this webinar. At Northwell Health, the Center for Emergency Medical Services is charged with transferring patients between our 21 hospitals. This includes the behavioral health population. They're transported from hospitals that might not necessarily have inpatient beds available for behavioral health patients. So we wind up moving these patients into the different facilities wherever patient beds become available at the time. During those transfers, as we've been speaking about before, a lot of the concerns that we have are how these patients transferred, how they're transferred safely to not only protect the patient, but to protect the crew as well. Jonathan mentioned that earlier, that this being a passion project of his, this stemmed a lot of what we've put together in the health system, stemmed from an incident that took place in the spring of 2011, where a routine behavioral health transfer went horribly wrong for one of our crew members. Next slide. So in this slide here, before we start the video, I just want to give everybody a little bit of a background. This video is taken by a bystander who witnessed this incident where a behavioral health patient escaped the safety straps during the transfer on the stretcher and was able to rip the paramedic's PCR laptop away from him and violently assault him multiple times in the head, causing severe career-ending injuries to the paramedic. If you want to run the video. The video here shows that the patient is still in his hospital gown. To the right on the ground, you'll see the paramedic that was just assaulted. As this is happening on one of the highways on Long Island, the patient actually walks across the highway. Several bystanders stopped to come by to try to assist. Several of them are actually off-duty police officers who are trying to talk the patient into going with them. He would have none of it, and as you see in the video, he actually gets across the other side of the road and absconds with another vehicle that he winds up driving away with. During this time, this led to obviously the police being involved. They wound up chasing this gentleman for over 40 minutes and finally was able to subdue him near Yankee Stadium, and it took multiple people to finally get him together to get him safely transported to the hospital where he was ultimately treated again. So, you know, we have to kind of look at this after this incident took place to find out where did this supposedly routine transport go wrong? And were there any indications here that we had to concern ourselves with prior that we may have missed? Next slide. So just a brief background in regards to this. This is a middle-aged male walked into the emergency department with his brother. He had a complaint of losing it, stated that he was seeing dead people and receiving demonic messages through television and radio. There was no prior medical or psychiatric history, no meds, no allergies, and denies alcohol or drug use. He had a general history of depression that had gotten worse over the last 2 months, and his initial vital signs were stable. Next slide. The initial behavioral health ED diagnosis was major depressive disorder with psychotic features. The physician ordered 2 milligrams of Ativan Q6 for anxiety. At the time in the hospital, this patient was so calm that they weren't even on one-to-one observation in the hospital ED. The patient voluntarily admitted himself for behavioral health services. And unfortunately, the closest facility, which literally is across the parking lot, which is our main behavioral health facility, had no beds available. We wound up having to transport this patient to a secondary facility, which is about 22 miles away. And again, during the time that the crew transported the patient, everything was stable.
Thanks, JJ. So yeah, then after this all happened, we had to really take a hard look at what went wrong, what did we miss? Like JJ just said, this patient presented as a very mundane case, a relatively young gentleman with very little history, and really came in with the hospital with chief complaint of just having a rough time. Found out that his significant other was pregnant, dealing with a lot of stress. But definitely some red flags in there that we may have missed along the way. So what do? We use a root cause analysis approach, and that's just that, to figure out what the root of the problem was. We don't want to just kind of assign ad hoc fixes. We want to really get to the root and see what the issue was. So this is just kind of a visual of the different risk reduction and corrective actions you could take. You have physical plant changes, which are the most impactful, where you're actually making physical changes to whether it's apparatus or equipment. You have redundancy, like checklists, which we use, and you'll see, and even training, which interestingly enough is considered less impactful than some of the other measures. So what do we learn? Looking back, just a 30,000-foot view, this patient population, they can have very unpredictable and in this case very dangerous behavior. Like JJ said, our provider was assaulted severely, and unfortunately was unable to ever return to the field of pre-hospital care. We learned that there's things in the back of the ambulance that could be used as a weapon that you wouldn't think. We've used for several years Panasonic tough books. They're great because you can drop them down a flight of stairs, but they're also could be very dangerous when they're swung at a provider or anyone for that matter. So adding to that, we can do more. We can do better to protect our crews and our patients when we're doing these transports. As we took a deeper dive, something that we've dealt with for many years is, Craig spoke to it earlier, some of the regulatory challenges that you face with these type of, especially interfacility transfers. New York State, we're governed by the mental health, Office of Mental Health and mental health laws. Lots of red tape and lots of signatures and voluntary versus involuntary, multiple physician signatures required in order to authorize transport. So a lot of factors at play for these types of assignments. So we got right to work. This was unfortunately a benchmark event, and not in a good way, because one of our employees got hurt so badly. So one of the things was let's educate our staff. So we use PMCS which is a combination of de-escalation as well as physical defensive movements. Obviously, we'd like to start with the least restrictive de-escalation techniques. And I think some of the irony behind this is, when you look at emergency or 911 type calls versus interfacility calls, the assumption is that the emergency ones, the ones that you have all the unknown and lack of predictability, are the ones where you run into a lot of risk. There's always risk on all of these, but We find that many of these could, quote unquote, controlled transports where someone's going from one healthcare facility to another often pose a huge amount of risk. So in addition to training our staff, we implemented some of the physical plan changes. On your left, you see our safety net. The safety net we created to keep our providers safe. It creates a physical barrier between the patient and the provider. The nice thing about this is it can be deployed and taken down in a matter of seconds. All of our every single ambulance in our fleet, which is over 100 vehicles, has this net capability. And it's essentially a quick fasten, quick release setup where you can put it up and take it down. You're able to monitor your patient even when this net is up. So if this patient requires any sort of advanced life support monitoring, visual monitoring, you can do all that and still have that physical barrier. In addition to that, there's other things on the back of the bus like oxygen tanks, equipment bags. So we remove all of that stuff from the patient compartment and either put it in outside compartments or at the very least on the side of the provider, on the other side of that safety net, to deter the patient from having any sort of access to something they could weaponize, for lack of a better term. We keep our monitor on the provider side. We're able to just run the cable through the net if needed. But even things like, the straps on the bags, we try to really minimize what the patient has at their disposal to avoid any further issues. Another measure that we took was on your right, you can see our 5-point harness buckle guard. So our buckle guard is a level 1 restraint. So it does need a written order from a physician, which is something we worked out with across our entire health system to kind of have as a standing order. But this level 1 restraint allows you to secure the patient in a 5-point harness, like many stretchers have. But as you can see, there is a guard. There's not a regular button. You actually need a pen or a pin or something slim enough to pop that little button in the middle to release. So the patient is not able to release themselves from this device. We found this to be an extremely effective just deterrent. If they go to grab at it and they realize that they can't get out, it's a good cue for our providers. But we've also seen it act as a passive deterrent from further escalating this type of incident. So just to add to some more of the risk mitigation follow-up, we have a crew checklist that we put in place. And as you can see, this is wordy. It's long. There's a lot of boxes to check off. So this is not something that we necessarily use as Bible, but it's a resource for our crews. It's not built into the PCR, but it is provided on our tablets so they can look at it. And if they want to take that extra step of safety, which we certainly encourage, they can walk through this checklist. It provides that redundancy. It provides that second step to follow up on everything to make sure that we've taken all precautions to keep crew and patients safe. And with that, I'll hand it over to Viktoriya Monosova.
Thank you, Cono, and good afternoon, everyone. So the policy that you see here displayed is our interfacility behavioral health transfer policy. So this policy will be available to everyone for access post-presentation. Some of the important key factors of this policy are definitions that are provided regarding level 1 and level 2 restraints, as well as proper utilization and placement of the safety net, which was shown in the previous slide. One key note is to make sure that no family member or staff member accompanying the patient gets trapped in the patient compartment area with the patient behind the safety net. They may accompany the patient, but they have to sit in the front cab of the ambulance. Additionally, supervisor approval to remove the safety net is necessary as part of our policy. A discussion must be had with the crew and the paramedic supervisor in order to be given direction to remove the safety net. The two bullet points that are highlighted in this on this screen right now are directly out of the policy and provide specific instructions on what to do in case of a medical emergency versus a behavioral emergency for these patients during transport. In both cases, the crew safety is our number one priority, and ensuring that the patient is actually having an emergency is necessary, as well as before tending to the patient. The monitored pulse oximeter can help to identify in some cases if an emergency is occurring. For behavioral emergencies, it is strongly advised for a 1013 signal to be initiated. That is our signal for an emergency, and the crew is to remain in the front cab of the ambulance until help arrives. Next slide, please. So this is a copy of our department interfacility protocol. These specific protocols are to be used as a guideline by our providers. A few key components of the protocol to note, which are crucial to these transports, include bringing proper paperwork along with the patient to avoid any unnecessary return trips to and from the receiving facility. A lot of the times, the facility that the patient is being transported to will not accept the patient unless all the proper paperwork is provided. And it's crucial that that paperwork is identified prior to leaving any sending facility. Additionally, proper steps to take, which are mimicked by the previously discussed policy. If a patient begins to show any signs of agitation during the transport, those steps are also outlined in this protocol. Another point to mention is the use of restraints, which will be touched on in a different slide. However, the presence of a supervisor is necessary for application of the restraints, as well as assessments by the provider every 15 minutes during the transport. And as Cono mentioned in the previous slide, the monitor cables can be strung across through the net in order to monitor pulse oximetry. Another very important factor on the protocol is proper pre-medication is always discussed prior to having the patient leave the sending facility. And as I mentioned, this will also be available to everybody for view after the presentation. Next slide, please. So an unusual occurrence report is a red cap generated survey that we utilize to record any incident that may involve any sort of risk management or require further evaluation or investigation. So the highlighted portion of this form shows that this tool is used in order to track any elopements or attempts for elopements. Post-report of this red cap survey unusual occurrence, we typically do an RCA or root cause analysis. It's conducted to find ways to improve on processes and procedures to avoid any further incidents from occurring. So this is our workflow on how a behavioral health transfer is initiated and assigned to a crew. After a call is received from a sending facility, dispatch information is generated via the call intake process, which I will discuss in the next slide. An appropriate unit is then assigned based on a few key questions. CAD data is generated and available for the crew to view, and it's imperative that they read this CAD data prior to arriving to the facility to better prepare themselves for the patient. Next slide, please. So this is a list of questions asked by the call taker to identify the proper response to the assignment. A few key questions included, a few key questions for us to take note of is the diagnosis of the patient, whether the patient is a minor. This will trigger additional steps to be taken, such as ensuring that a guardian is present for the trip. In order for a minor to be transported to a receiving inpatient psychiatric facility, their guardian has to physically sign them in to that facility. So we make sure to stress that to the crews, and that's one of the questions that's asked in the call intake process. The need for 4-point restraints, this typically triggers a supervisor's response to the assignment, and whether the patient receives medication for agitation within the past 3 hours. This will also indicate a paramedic response as well as a supervisor response. Any active evidence of psychotic features or auditory or visual hallucinations is also an important question, as this will also trigger a phone huddle response as well. And I'll talk a little bit more about that shortly. And these intake questions are periodically looked over in order to incorporate any improvements identified during RCAs or from feedback that are provided from our operations team. So what you see on the screen now is a CAD an image of a CAD. So all those questions I just discussed are listed in this CAD, and the answers are listed next to them. So whether the question was answered yes or no. What I highlighted on the screen here in yellow, this indicates a BLS response. So that means that 2 EMTs are able to respond to this type of an assignment, and that a paramedic and a supervisor are not required. So the crew, this CAD data, it's important for the crew to read prior to going into the call, so that they're prepared to see what kind of an assignment they're responding to. So the 3 types of responses that we have is a BLS response, a ALS ops phone response, and an ALS ops response. So BLS response includes any discharge home from an emergency department for a patient that has a psychiatric diagnosis or was evaluated for a behavioral incident. This can also include a discharge to a group home or an inpatient psychiatric residence. And additionally, a patient being admitted for a new inpatient psychiatric admission. This patient can be transported with an EMT in the back of the ambulance assisting the patient behind the safety net, and an ALS response is not required. ALS ops response, this signifies a patient that requires transport for an inpatient psychiatric admission and has not been given any IV or IM medications for any type of violence. It also signifies that the patient does not exhibit violent behaviors towards themselves or others, and do not require 4-point restraints. The huddle typically occurs, this is for an ops phone response. The huddle will typically occur between the crew and the staff before the supervisor is contacted via phone to answer a series of questions, which will be shared in the next few slides. And these assignments require a paramedic to be in the back of the ambulance with the patient. And the last type of response is the ALS ops response. This is a patient that has received IM or IV sedation, or has a history of violent behavior and may require 4-point restraints for transport. The supervisor, crew, and staff at the sending facility are all part of the huddle. And this is in order to ensure that any safety concerns to everybody, including during the transport, are addressed. A paramedic must be in the back of the ambulance for this type of an assignment, and will be monitoring the patient from across the safety net for the duration of the transport. And I will now pass it over to JJ.
Coming back on. Thanks, Viktoriya. Okay, so what does the crew look like? What are they doing when they arrive at the scene? A couple things that they need to get set up in the ambulance before they make their way into the emergency room is to have the safety net secured in the back of the vehicle. They're going to then make their way into the hospital to speak with the crew. To speak with the hospital personnel. When they're doing that, they also make sure that the personal belongings of the patient and the equipment is for the ambulance is secured appropriately away from the patient. The patient's personal belongings will actually be carried on the side of the net where the paramedic or the EMT is in the back of the ambulance. The other thing that we make sure that we do is that we have the patient remain in the hospital gown and without their shoes. Their clothing and everything else gets brought with us, and that we give that off to them at the arrival of the receiving location. When we moved into the emergency room and we meet up with the BH team, we have a behavioral health huddle, and we go ahead with the assessment of the patient. Next slide, please. We use the team steps approach. This is a collaborative setup where we huddle together with the BH transport crew, the nurse and the physician that was managing the patient, to go over the information that was presented previously to make sure that everybody's on board with what the patient's history was, what medications they may have received, what the expectation is during the transfer, and the level of restraint that needs to be done for this patient. If at any time during this huddle that takes place, there is somebody in the team there that believes that this is not a safe transfer, the entire process stops, and then there's additional people that get brought into it dependent on what the concerns are. Those are then relegated to trying to figure out how to best manage this, and once everybody's in agreement that we're going to go with the plan that's agreed upon, then we go ahead and move forward with the transfer. Next slide. The behavioral health huddle checklist is incorporated into our PCR so that the crews can, Cono, I showed the flow sheet before. This is a little bit of an easier thing for them to do within the PCR to basically answer whatever the questions are as far as the patient status that gets included. Next slide. This is a copy of, These are pictures of our 4-point restraints. Viktoriya had mentioned before, the only ones that are trained in appropriately applying the restraints are paramedic supervisors. So when we have a restraint, they're obviously there to be able to do that. And we can hit the next slide. What you see on the slide here is the restraint and sedation difference between in-hospital and the pre-hospital side. A lot of times the hospital use leather restraints. We go with the soft restraints. And then if there's whatever the medication is that they're going to wind up utilizing for the patient prior to the transfer is on your left, and the medications that we use, midazolam, ketamine, are on the right, which you can utilize to sedate the patient further during transport if needed. Ultimately, what we want to do is make sure that the patient is sedated enough prior to the transport that we won't even have to worry about sedating the patient during the transfer, because at that point, then you have to worry about bringing the net down and actually physically managing the patient, which we're trying to avoid, again, for crew and patient safety. And Cono, I believe you're taking it up from here, correct?
Yes, sir. Thank you, JJ. Yeah, so, this is a lot of steps. This was kind of one call we walked through. There's a lot. This is a very much a dynamic and fluid approach, because these tend to change. We see different trends. It's a moving target. So, what do we do from here? How do we get better continually? For one thing, we always want to educate our staff through continuing education. Make sure everyone's aware of the potential harms, dangers, and everything that goes along with these jobs. We are currently looking at our policies, our procedures, and how we're treating these patients. What we can always do better. We have to look through that lens and make sure that safety, both crew and patient, are at the top of that view. Luckily we do a lot of these, luckily or unluckily, in a good way. Last year we did almost 7,000 interfacility behavioral health transports. So we have a lot of great data that we can pull from our PI system and see what kind of trends exist. What we saw in 2011 and what we see today is very different. And it's not just a matter of volume. COVID and other things over the past couple of years have shined quite a light on mental health in general. So we've seen a stark spike in numbers just since 2020. So this year we're already closing in on about 5,000 of these interfacility transports. Keep in mind that we haven't even discussed our emergency stuff, which is a huge number. But this is just our interfacility stuff that we try to really have a good grasp. And, really, at the end of the day, it's all about risk mitigation. And using the RCAs, the risk factor is never going to be zero with these. That's the hard truth that we've realized. But by mitigating and lessening those risks and those exposures as best we can through precaution, through review, through PI, through all those things, we strive to keep everyone safe. So we've come a long way since that terrible video that you saw back in 2011. But the fact is we can always improve. We're not perfect. I don't know that we ever will be. But I think we're moving in the right direction, and I think we do a good job with it, and just working every day as to how we could get better. So we appreciate everyone's time in listening. I think next we're going to turn it over to Q&A with Mr. John Washko and folks. But thanks again.
Thanks, Cono. I'll ask everybody to come back on stage and open up your mics and your cameras for some Q&A. Looks like a lot of the questions have been are being answered by our speakers as they've been getting typed in, which is great. I appreciate that. A couple of open questions. One is for the Northwell team on the buckle guard. Do we just use that on the chest strap, or is that used on all the straps on the stretcher? Cono,
Yeah,
you want to take that?
Yeah, great question. That is just on the chest strap on that 5-point harness. You know, like I said, we found it to be an excellent deterrent. We didn't, you know, you can overdo it on some of this stuff. It is a level 1 restraint, so that's something you have to navigate carefully. Luckily, we got great support from physicians throughout our health system in making that essentially a standing order for these types of transports. But yeah, to answer your question, just on the chest piece.
The other piece, when we had incorporated when we started to look at the buckle guard, that question actually came up. And the concern wound up being, God forbid you get into an ambulance accident, having all 3 of those straps in the buckle guard format will be a little bit difficult to get loosened or released fast enough should something happen in the back of the ambulance and you have to get the patient out of there quickly. So what we've seen historically is that utilizing the chest strap with the buckle guard has given us our greatest opportunity for safety and deterrent for the patient.
Thanks, JJ. Another question that's come up, I'll just throw this out to the group for both programs to answer. Does your protocol ever identify less than 4-point restraints if restraints are required? Craig or Jasmine, you want to answer for Pinellas County?
For us, we are either 4-point soft restraints, especially for the elderly, or 4-point hard restraint.
Great. And how about on the Northwell side?
To our protocol in regards to restraints, we typically look not to use restraints, and we stress that the patient should be pre-medicated to avoid the need for restraints. That's a last resort. Obviously, we understand that some patients will still require them, but the protocol specifically states that if the patient can be medicated and not restraints, that we should go that route to avoid restraints.
Great, thank you. One of the questions that came up is a great question here from Thomas. Any suggestions from the group regarding pediatric or teen mental health behavioral patients? Any special handling, any special circumstances, anything that either of the programs do differently?
Yeah, John, I'll take that. I'll kick that one off. With pediatrics, I know that a big thing is, you know, we're always making sure that we have someone to escort the patient, especially on the interfacility side. However, you know, mom or dad or family that's there may be a huge trigger for that child. So something to keep in mind, where you may have to bring these folks with you, whether it's their parents or guardian. They don't necessarily have to sit in the back with the patient. Maybe it's safer to keep them up front and away from the patient, even though they're in the ambulance. Just something that we've come across time and time again.
We've also found in the huddle, when we're talking about these patients, a lot of times, if these are children that have long-standing histories, a lot of times that they have opportunities to use different methods dependent on the patient to help keep them calm. If there's a distraction there, whether it's a favorite toy, a lot of times what we'll do is if there's music that works for them, the crews will stream that music through their own personal devices to kind of work towards keeping the patient as calm as possible. That's where the huddle is so beneficial to talking about all of the elements of this patient and the care that they're being received, so that when we take them out of the uncontrolled environment of the hospital and they're in the ambulance with us, we're doing the best that we can to make sure that the patient is as comfortable as possible during the transfer.
So we rarely transport the parents with pediatric psychiatric patients here. So that's interesting. That's very different. And we don't have a lot of pushback or problem with that. A lot of them are already admitted and accepted to the facilities when we transport them, if it's an interfacility transport. And we try to put the person who has the best rapport with the patient in the back with the patient. And we do this. We have similar techniques. Obviously, we put on some music or something calming. And our clinicians are really well trained in how to interact with these patients. So we don't really see very many problems with the pediatric patients, and the parents don't usually volunteer or ask to come on these transports.
It's very interesting.
Yeah, I think on the flip side, is the parent part of the solution or part of the problem is something that we assess, pretty quickly.
Especially for that age demographic, that probably plays into it probably more often than not, I would imagine.
Yeah.
Unfortunately, with us, the problem winds up being at the receiving facility just because of the legal constraints. They actually need to have that parent there. And what we've found in the past is we'll have the parents say, "Oh yes, we'll be there," and then the next thing you know, 6 hours later, they haven't arrived. The facility can't accept the patient, and unfortunately, it's happened more times than I care to admit to. We've actually had to transport the patient back to the sending facility until we were able to get the transfer secure, because the receiving facility couldn't accept the patient without the legals being signed by the parent. And the parent actually has to be there to do it. They have to do it in front of the receiving facility.
Interesting. In Florida, we don't have that requirement on the patient signature. So we're always checking, will the receiving facility accept before we start the transfer, which is a lot more straightforward.
Great, thanks, guys. Another great question that's come up, and I know it was briefly mentioned by both programs. Could you talk more about your de-escalation and defense programs that you guys teach your paramedics and EMTs?
So over at Northwell, we utilize PMCS, which stands for Preventing and Managing Crisis Situations. There's a hands-on portion where, the providers, EMTs and paramedics come in and do actual physical hands-on stuff to practice defense and restraint techniques as a last case resort. And then there's also a portion which they view videos and go through didactic material in regards to de-escalation techniques, awareness, calming, and the slide that Cono sort of touched on, different measures and techniques on how to avoid and prevent the patient from acting out.
And for us, our core curriculum came from NAMI, the National Alliance for Mental Illness, and they have a crisis intervention team program training. It's 40 hours for law enforcement. We took and I have that kind of time. We don't have the money the cops do. So we took and reduced ours down to a regular 2 to 3 hour continuing medical education. Am I close to accurate on that, Jasmine?
Yes, and then we, through our continuing education cycle, we do different types of training to, refresh that. Also in our onboarding academy, we do a little bit of mental health training, and we bring in a mental health professional for 3 hours to work with all of our new hires at our fire department and at Sunstar.
Great. So a couple of other questions that have come up. Okay, we've already talked about the training programs for de-escalation. Question on cameras. Craig, I think you mentioned maybe you guys use cameras in your MHT program. Could you talk more about that and what type of cameras? How long do you keep the video, audio footage? Any best practice you could share?
Sure. It is really like a dash cam, and we have it on a loop so that we're not creating a permanent public record. And that loop probably goes within a couple of days. It overwrites. It is, pretty much, what you'd consider a regular dash cam type of an approach. We don't use body cameras at all, but we're starting to, see that come up, pretty regularly with law enforcement now.
Great. I don't know, anyone on the Northwell side? I know we just recently implemented a camera program, at least in the front. Anything, Cono, maybe you could talk about on that that you'd want to share?
Sure. Yeah, we don't have anything currently in the patient compartment. Right now, we have a dual facing camera that shows both the cab and the front for accident or activity in front of the ambulance, but nothing at this time in the patient compartment.
Thank you. So another question, and this is an interesting one, especially in the face of ET3. Northwell is a participant in ET3. Craig, I'm not sure if Sunstar is or not, but
Yeah.
one of the questions that came up is there a possibility to downgrade a 911 mental health call to an MHT transport and maybe go directly to that behavioral health assessment facility? Have you guys progressed to that level at this point?
Yeah, we've not at this point, but we've got a committee that's our transportation exception plan, is something that you file in Florida of how you're transferring mental health patients. And I think that you may see us move away from law enforcement transport and have us do that. At some point, I could see us expanding that and downgrading from ALS or BLS or law enforcement to advance service, but we've not done that at this point.
Yeah, on the ET3 side, so we're doing a large regional ET3 project in New York City in partnership with the fire department in New York, as well as all of the other voluntary hospitals in New York City 911 system. And part of the plan with that will be if there's a behavioral health patient that meets certain criteria that a different type of team would respond, a mental health team or mental crisis team respond to the scene to de-escalate and likely manage the problem versus transportation to the emergency department. So I know that's kind of in the future plans right now anyway in New York City. I believe there's other programs out there, even just doing in the community paramedicine realm, or in similar motivations, I'm sure, here to get the right patient, the right type of care at the right place in the right time. So I know there's other programs out there as well. Great stuff. Let's see. So is anyone using a specialized MHT from a behavioral health facility as an integrated team member in any of your circumstances? So are you bringing any of the personnel maybe from the treatment center with you, or using a unit from there to potentially transport these patients? Anyone have any experience with that?
We don't do, because typically they're short-staffed and can't leave the facility. But we are doing that handoff that I was talking about to make sure that we are on each side having a couple of hands on.
Great. There was a question about the 8-hour curriculum, Jasmine, that you mentioned. Is it possible that you guys could share that curriculum with the group?
Yes, on next Monday, we are actually having a class, so we're reviewing everything that's going into that right now, but I can share that with this group here shortly. And 4 hours of that is the sheriff office training that we've added, so.
Got it. Last question that we have. Do any of your agencies delay mental health transfers during the evening or the overnight, especially long distance transfers from a hospital to a mental health facility?
So for us over in New York, that's probably one of the best times to transport patients, considering the traffic that we don't really have to face. So we don't typically delay it unless the receiving facility has any reservations for accepting or admitting patients within certain time constraints. But other than that, that's a great time for us to do these transports.
Yeah, well, we found, actually, to Viktoriya's point, we actually just completed a transfer. We had a patient that needed to go to a secure specialized facility 6 hours away from where the patient was. And to get out of New York and avoid the traffic, we actually moved the patient at 3 o'clock in the morning. The transfer went great. As a matter of fact, that was also part of the strategy of moving the patient. The patient generally sleeps at night. So they medicated the patient. They actually kept them up during the day so that they would sleep more during the transport. And luckily, the transport went off without a hitch.
Sounds like going on vacation with your kids.
Exactly.
We don't delay our transfers at all, but if it's a surrounding county, then we do not go by van service, without by ambulance.
Another great question, and I know a lot of us are dealing with this because the behavioral health transport, the out of county or out of town behavioral health transport volume continues to rise quite substantially. And so there was a question of how do patients relieve themselves on these trips, and what plans do you guys have in place for those kinds of things?
Speaking back to the transfer that I just referred to, part of the care plan of moving this patient was to make sure that they actually had a pull-up on, so that we wouldn't have to stop. That, you're right, there's a great risk in regards to that. That's how we were able to mitigate that. It's all part of the planning beforehand. You really have to kind of think about, dependent on what you're dealing with in those transfers, what obstacles might be there that you may have to solve for.
Fortunately,
Right, I think it,
for a long
go ahead,
distance.
Greg.
Fortunately, we're not going ultra long distance. Like you are. Typically, we're going surrounding counties, so it's less of an issue for us.
Viktoriya, were you going to add something? I thought I saw you come on.
Yes, it's actually part of our checklist to make sure that the patient is comfortable and ensure that they use the restroom, need any food or drink prior to leaving. We're not going to give them a full meal, but if they need a snack that's going to carry them over for the trip, then we make sure that they're comfortable for the trip. That's going to happen.
And when all else
Thank you.
fails, we have the urinal and the bedpan on the bus. Hopefully you don't have to use them.
Yes, same for us.
Yeah, I can imagine that would create some challenges just from a safety perspective again. If it had to be done, I assume we would probably do a pullover, use two people in the back kind of approach if something got to that point, in a safe zone, safe area, something along those lines. Great questions. So, I mean, it's interesting to look at the two various programs. Craig's program is more of a government run, by the county service, which is something actually we've always wanted to try to build on the private side here. It's been a little more challenging for us, just because we tie up so many EMS resources doing these behavioral health transports versus an integrated health system. So our EMS agency is part of a very large healthcare integrated delivery network. And so the amount of integration that you hear and how deep we go with our clinical teams, our service lines, the huddles and the team steps approach is definitely very much more of a kind of a healthcare approach versus a kind of a public safety approach. And Craig, I'm interested, what was the birth of the genesis of the MHT program? Because I've only seen, there's only probably a couple places in the US that have something like that. I think it's a great model. And I'm curious, I saw a little bit of some of the things you were talking about on the funding side, but is that taxpayer supported, or do the hospitals cover all of those costs?
Yeah, that's a great question. I didn't think to put it in my slide set. Sorry, my volume was, I'll try to speak up better on the QA part. So interestingly, in Florida law, under the mental health code, the secondary transport for mental health is the responsibility of the county. So county government, not necessarily the EMS system, has a responsibility. So for us, the easiest way to deal with that was to take and stand up that van service. We had our law enforcement didn't want to handle it. We really didn't want to contract it out to yet another provider, so we integrated into the ambulance contract.
Yeah, it's a great program. Like I said, we wanted to try to do something specifically here for our behavioral health, just because the sheer volume of calls that we do, is significant and it is a large burden on the EMS system. So kudos to that solution. It's tougher when you're trying to do it by yourself versus when you've got the government behind you to help you with that. So it's a great solution for the citizens.
We have a problem either way as county government. So EMS became the solution for that. And it also is kind of loss leader. It's a bit safer for us, and we do bill the hospitals. They were happy with it because they were paying a full, retail ambulance bill, so we got that cost down for them. But we're not really getting, much in the way of reimbursement otherwise.
Great. So there's a question on air transport. Are the precautions used similar, or were they, I guess, maybe are they designed around air medical? Because I know in an air medical situation, and actually that brings up an interesting topic, because in the air medical world, usually they're chemically restraining someone versus sedating someone, right? They're actually paralyzing someone like an agitated patient prior to transport in the helicopter, using paralytics and then usually controlling the airway with some form of advanced airway versus sedation. That's actually one of the things at the national level when we were talking about that there's that I think we should stress that there's a big difference between restraining someone and sedating someone. And oftentimes people say, well, he's restrained, he's got Haldol on board, or, he's been given a sedative, so therefore he's chemically restrained. And I think it creates kind of a false sense of safety, right? And so it's definitely one of the learning things we had as we went through this project, is to make sure that's well defined and that people understand those differences in terms of that. In terms of other air transports, I'm not sure, I've not been exposed. Our program doesn't do any mental health transports that are non-emergency or non-medically related within our rotor wing program. We've actually had some discussions because of how far we're going to potentially bring having to use maybe fixed wing resources in the future, just again, because capacity is such a major issue here in New York, and getting patients the treatment they need can be 12, 14 greater hour kind of, situation for our patients. Obviously the very challenging aspects associated with that, with just the expense and the lack of reimbursement for something like that. But it's definitely something that I know has slowly started to creep up on our radar. So this has been a great session, everyone. Maybe I'll go around the room and see if there's any closing comments before I'll turn it back over to Amanda for close. Craig, how about from Pinellas?
Yeah, thank you all. We appreciate just sharing what we're doing. It's not rocket science, but just sharing kind of what we've been doing. Overall, I think we've been pretty happy. That's pretty safe, but something that we're always kind of reevaluating to get better. So we'll take a couple of things, lessons learned from you guys, and try to keep getting better as we go.
Likewise. Jasmine, any parting words, any words of wisdom?
Thank you for the opportunity to be a part of this. And it's really interesting to hear the differences across, different agencies in different places in the country and how we all do things. So we can all learn from each other and grow.
Cono, how about you?
Yeah, great to get on with some folks from out of town and hear how you guys do things. Craig, kudos to you and your team on some of the responder, wellness. I'd love to bend your ear a little bit about that one of these days. And but thank you to everyone for joining. And like we said before, this is a moving target and something that we work at every day. So constantly, evaluating and reevaluating.
JJ?
Yeah, knowing the amount of, first of all, thank you all very much for taking the time to listen to us today. I hope the information that we gave you helped. I'd also impress upon everybody that collaboration, as we continue to have this patient population evolve and get larger and larger, is that the more we collaborate on how to do these to keep everybody safe, patients, bystanders, the crew, the more we talk to each other, the better off we're going to be as a profession to be able to manage these. Historically, you look at the EMS providers are all usually hey, let's just get the patient out of here because we got to get them to move to the other facility. And nobody ever took the time to think about the riskiest part of the transport is actually moving the patient. That used to get forgotten about, but luckily more and more people are paying attention to it. So to my initial point, let's make sure we all work to collaborate together on these things, and hopefully we'll come up with really good ways of being able to do this going forward. Thanks, John.
Thank you. And Viktoriya?
Thank you for the opportunity to present, and thanks for everyone who joined. As mentioned before, mental health is an ever-growing topic, and it's just going to continue rising. So, we hope to learn from others as well as improve on our standards and procedures in order to ensure that, our crews continue being safe and that the patients are transported safely. So thank you.
Thanks, Viktoriya. And just looking at the final comments, I think Cornelia said it best for all of us. We all have lots to do, and we still have a lot to learn on this particular topic. So thank you very much. I'm going to go ahead and pass it back over to Amanda for final closing.
To echo all of the panelists, thanks to everyone for joining us for this Academy of International Mobile Healthcare Integration webinar. We will post the recording to the AIMHI website no later than tomorrow. And we will also include the slides and the various reference materials referenced by the panelists today. So please do take a look at AIMHI.mobi, M-O-B-I, tomorrow to catch up on the recording as well as these materials. Thanks so much, and we hope to see you on a future AIMHI webinar.